This question is asking which represents the pathophysiology of type 2 diabetes mellitus: insulin resistance, beta cell dysfunction, alpha cell dysfunction, or antidiuretic hormone deficiency. Now, this is a very straightforward question, and honestly maybe one that you knew the answer to before even starting dental school. But just in case you didn't know, you forgot, or you got it mixed up with other types of diabetes, let's go over this question and diabetes as a whole. Diabetes is a group of metabolic disorders resulting in hyperglycemia, and it's a defective or deficient production of or response to insulin. Now, insulin is a major anabolic hormone that allows glucose to be transported and stored in cells within the body after meals. There are two major types of diabetes, which I'm also sure you're aware of: type 1 and type 2. Type 1 diabetes is typically seen in younger patients and is characterized by decreased blood insulin. Type 2 diabetes is seen in older patients and is associated with obesity, but the insulin levels in the blood may be normal or increased depending on the cause of the condition. Now, both types of diabetes can have a number of complications and symptoms. Diabetes is the leading cause of end-stage renal disease, blindness, and lower limb amputation, and a number of other complications are also seen. As far as symptoms, the 3 P's of diabetes are very common and likely the most well-known symptoms, and they would be polyphagia, or extreme hunger, polydipsia, or extreme thirst, and polyuria, or increased urine production. But what is the pathophysiology, or what causes type 2 diabetes? Type 2 diabetes is not an autoimmune disease like type 1 diabetes, and is either the result of insulin resistance or decreased insulin secretion. The target tissues may not be responding to the produced insulin, or the pancreas may not be producing enough insulin for their body to function. And because of that, we know that the correct answer choice here is A, insulin resistance. This resistance is the hallmark of this condition. In the early stages of the disease, the body's cells, particularly those in the liver, muscle, and adipose tissue, become less responsive to insulin. When cells become resistant to insulin, the pancreas compensates by producing more insulin. However, despite the increased insulin levels, the glucose uptake by the cells remains impaired, leading to hyperglycemia and the symptoms of diabetes we discussed. This insulin resistance is due to a number of factors. Genetic factors, environmental factors, and lifestyle factors contribute to its development. One of the key risk factors is something that we could think of when we think of type 2 diabetes, and that would be obesity alongside a poor diet and a sedentary lifestyle. Type 2 diabetes also accounts for about 90 to 95% of all diabetes cases, meaning it's much more common than type 1 diabetes and other types. The good news is that managing type 2 diabetes, especially in the very early stages, can be much easier than managing type 1. The earliest treatments would be lifestyle modifications like changes in diet, increase in physical activity, weight loss, and stress management. Later treatments involve certain medications to improve insulin sensitivity or stimulate the production of more insulin. But if severe enough, then the patient may require insulin therapy to achieve better blood glucose control. So because this chronic metabolic condition is primarily due to insulin resistance, we knew that this was the correct answer choice. Now let's go through the other answer choices and discuss what they would contribute to. Start with beta cell dysfunction. Now, this answer choice may have sounded tempting as you may associate beta cells with diabetes, and that is true, but this is the cause of type 1 diabetes and not type 2. Type 1 diabetes is a chronic autoimmune disease where the beta cells of the pancreas get destroyed by self-reactive T cells and autoantibodies. This results in absolute deficiency in insulin production. These cells are located in clusters of the pancreas known as the aisles of Langerhans, and because beta cells specifically are the cells responsible for producing insulin. Like we said earlier, the onset for this type of diabetes is most common in childhood or adolescence, and it typically develops suddenly, unlike type 2 diabetes. And it's also much less common than type 2 diabetes. Because the beta cells in this condition have been progressively destroyed, patients with type 1 diabetes will need to supplement their insulin. These medications can be rapid-acting, short-acting, intermediate-acting, or long-acting depending on the patient, and they will also need to frequently monitor their blood glucose, usually through a pump that they wear. But because beta cell dysfunction is the main cause of type 1 diabetes and not type 2, we knew that this answer choice was incorrect. Next, we have alpha cell dysfunction. Now, these specific cells are also in the pancreas, and they produce the hormone glucagon, which is kind of the counterpart to insulin when talking about blood sugar regulation. Glucagon raises blood glucose levels by promoting the breakdown of glycogen, or the stored form of glucose in the liver, and it stimulates the release of glucose into the bloodstream. If these cells were dysfunctional, the body would not produce glucagon and would therefore be unable to increase blood glucose levels in times of stress, leading to life-threatening hypoglycemia. edema. Seeing as this is the counterpart of insulin and the hyperglycemia that is often seen when insulin resistance is present, we know that the progressive loss of alpha cells would not cause any type of diabetes and definitely not type 2. I do want to point out, though, that alpha cell dysfunction can occur in these patients, but this would be a later effect seen in a patient who is suffering from long-term dysfunction of blood glucose regulation. Because the insulin levels are not controlled, the glucagon levels will not be well controlled either, and dysfunction will begin to occur in the alpha cells. So because this is a later development seen in type 2 diabetics, and because it's definitely not the cause of the condition, we knew that this answer choice was incorrect. And finally, we have antidiuretic hormone deficiency. Now, you may not have already known this, but this deficiency actually does contribute to diabetes. But instead of type 2 diabetes mellitus, it contributes to diabetes insipidus. Rather than being due to problems with insulin and blood sugar regulation, diabetes insipidus is due to problems with water balance in the body, primarily due to issues with the antidiuretic hormone, or ADH, also known as vasopressin. This hormone is produced by the hypothalamus and stored and released in the posterior pituitary gland. ADH plays a crucial role in regulating the body's fluid balance, specifically in controlling the amount of water retained by the kidneys, and it also plays a role in vasoconstriction and raising blood pressure. When there is a deficiency in this hormone, it's due to a problem in the hypothalamus or posterior pituitary gland, such as from trauma, a tumor, or a genetic disorder. The lack of ADH results in the kidneys being unable to concentrate urine, leading to large amounts of dilute urine being produced and causing this type of diabetes. The symptoms of diabetes insipidus are similar to type 1 and type 2 diabetes, but are more centered around fluid, meaning you'll see polyuria and polydipsia, but not really polyphagia. But because this hormone deficiency, once again, has nothing to do with type 2 diabetes, like the question is asking, we knew that this answer choice was also incorrect. So when talking about type 2 diabetes, we know that the pathophysiology is primarily due to insulin resistance and not beta cell dysfunction, alpha cell dysfunction, or antidiuretic hormone deficiency. This question is asking, which is the average risk of HIV transmission after a needle stick exposure to HIV-infected blood? 0.03%, 0.3%, 3%, or 30%. So it definitely has a 3 in it. But overall, this is such an important question and is one that could be easy points for you on the boards as long as you know it. You have likely had a bunch of bloodborne pathogen training already and should have definitely learned the transmission rates for diseases like hepatitis B and HIV, like in this question. Now let's talk just a little bit about HIV as a whole and how it's transmitted before answering this question. Now the human immunodeficiency virus is a virus that targets the immune system, specifically the CD4 T cells. Signs and symptoms of HIV depend on the stage of infection. Initial symptoms include fever, headache, and sore throat, while later symptoms include swollen lymph nodes, weight loss, and diarrhea. Profound immunosuppression in patients with this condition can result in opportunistic infections, neoplasms, and other systemic effects. Head and neck manifestations are also very common in HIV and may even be the first sign of an HIV infection. There's no cure for this infection, but antiretroviral drugs are used to stop the virus from replicating in the body. If untreated, HIV will progress to AIDS, or acquired immunodeficiency syndrome, and this occurs when the CD4 T cell count drops below 200 cells per cubic millimeter. And for reference, a healthy adult has between 500 to 1500 of these cells. Now, as far as transmission, this infection can be found in most bodily fluids and is usually spread via sexual contact or injection drug use. The bodily fluid with the highest risk of transmitting HIV actually is blood, because it has the highest concentration of the virus and would be the most effective means of transmission. When a needle stick exposure occurs, the average risk of HIV transmission is B, 0.3%. Now, this may sound very low, 0.3%, and it relatively is, but that does not mean it is a risk that anyone should be willing to take. Proper needle safety is very important, as I'm sure you've learned, and in the event of a needle stick exposure to HIV-infected blood, the incident needs to be reported, the wound needs to be washed, and post-exposure prophylaxis may be indicated. So you take some medication to maybe beat that infection infection. Now let's quickly go through these other answer choices, but we know that they're wrong because the rate is 0.3%. So we know that 0.03% is incorrect because it's actually too low. The correct transmission rate, if we turn it into a fraction, would be 3 needle sticks out of every 1,000, and this percentage would be 3 out of every 10,000, which is not correct. This is too low. And 3% on the other side of things is much too high, and 30% is much, much too high. But I do want to point out that other bloodborne pathogens do have different transmission rates from HIV. For example, another bloodborne pathogen that you learn a lot about is hepatitis B, and that tends to have a transmission rate ranging from 6 to 30%. So this answer choice is more aligned to that pathogen, hepatitis B, than HIV, so be sure not to get them mixed up. So HIV, like we said, it's definitely important for you to know that the risk of transmission from an HIV needle stick is 0.3%. Don't get that mixed up with other bloodborne pathogens. This is an important number to know for your boards, and just an important number to know overall.
In this scenario, we have a 26-year-old female who's presenting just for a regular checkup. When we take the radiographs, we see that there is this widespread radiolucent lesion. Upon clinical examination, we find that the patient is experiencing no pain from this lesion. The adjacent teeth are vital, and then the tooth roots appear to be unharmed. So given this information, we know that the likely diagnosis is an odontogenic myxoma. And this is just a rare benign tumor of mesenchymal origin. So it will appear radiolucent with radioopaque septa throughout, and is generally found in the posterior mandible, scalloping in between the teeth and causing them to come loose. It generally is asymptomatic in patients. So we'll take a look at the other answers to determine why they are incorrect. First, we have the radicular cyst, which is a radiolucent cyst, and it will have a hydraulic-like expansion. It should be associated with non-vital teeth, but we are seeing vitality with the patient, so we know that this is an incorrect answer. And with a radicular cyst, it's usually associated with some type of trauma, and then we'll also have dull pain as well. So none of these findings line up with what we're seeing in the patient, so we know that this answer is incorrect. And then to the left, we do have a radiograph of what it would look like, and we can see that it is completely radiolucent, like I mentioned before. Next up, we have the simple bone cyst, which is a pseudocyst, so it will appear radiolucent, but it won't have that epithelial lining or fluid-filled center that's characteristic of a cyst. It is generally asymptomatic, so if it is identified, it'll be an incidental finding, kind of like what we're seeing with the patient, but the adjacent teeth will also be vital and won't undergo mobility or displacement. But we know that this answer is incorrect because it will be completely radiolucent and not have that radiopaque septa throughout. Finally, we have a calcifying epithelial odontogenic tumor, and this is an incorrect answer because it will be radiolucent with radiopacities that represent the calcifications. So it won't look anything like the calcified septa that are throughout the odontogenic myxoma. It is generally associated with teeth, as we can see in the radiograph, and it can present as unilocular or multilocular lesions. So now we know what all these pathologies look like.
We have a 48-year-old female who says, there are sores in my mouth which hurt. She has photosensitivity. Her elder sister was diagnosed with Sjogren disease 2 years ago. She smokes occasionally. She's taking Aleve. Her blood pressure is normal. Her temperature is high. She has a fever. And there are oral ulcerations seen on her labial and buccal mucosa. And we're being asked, which condition is the patient likely suffering from? Impetigo, systemic lupus erythematosus, erythema multiforme, or an allergic reaction? Now, we are definitely given a ton of information in this question to be able to make the correct diagnosis. The first and most helpful clue is the image that we're given. If we look at this picture, we see that this patient has a bilateral rash on the cheeks, and it does not spread to the eyes or down to the nasolabial folds. This rash is very characteristic for a certain condition and should immediately point you towards a specific diagnosis. Another helpful clue is the fact that the patient has photosensitivity or sensitivity to sunlight. And the fact that the patient's sister has Sjogren's disease should also stick out to you. Sjogren's disease is associated with another autoimmune condition 30% of the time, and both have strong and both conditions have strong genetic ties. A final helpful clue is these oral ulcerations on the labial and buccal mucosa, which are also the patient's chief complaint. Although oral ulcerations can be seen in a number of conditions and can present in a number of ways, these ulcerations seen in conjunction with these other symptoms really only confirm the diagnosis we should have had in mind by this point, and that diagnosis would be B, systemic lupus erythematosus. Now, lupus erythematosus is the most common collagen vascular connective tissue disease in the US, and it comes in 3 forms, but we'll focus on systemic lupus erythematosus specifically because that was the correct diagnosis here. This condition is much more common in females, like our patient, and the average age of diagnosis is 31 years old. The condition has a waxing and waning nature, and the initial manifestations are typically a fever, like our patient has, weight loss, arthritis, fatigue, and general malaise. Oral involvement is seen in 5 to 25% of lupus patients, including ours, and these can present as lichenoid or nonspecific ulcerations on the palate, buccal mucosa, gingiva, and vermilion zones. This condition also typically presents with this characteristic butterfly rash in the malar or cheekbone area that spares the nasolabial folds, and the condition presents with skin lesions that flare with UV exposure in response to that photosensitivity. There are a number of other less common manifestations of the condition that can certainly be seen as well: renal symptoms, heart issues, headaches, and hematologic symptoms. Because lupus can involve a number of symptoms and often presents very differently between patients, it can be hard to diagnose. Treatment varies based on the specific symptoms and presentations, and the prognosis is also very dependent on what organs are affected. So although we know this is the correct answer based on the malar rash we can see, her photosensitivity, her oral ulcers, and her sister's diagnosis of Sjogren's disease, let's go through the other answer choices and briefly touch on what they are and why they would be incorrect in this case. And we'll start with impetigo. Now, this is a common and highly contagious skin infection, primarily affecting young children, though it can occur in adults as well. It is caused by bacteria, most commonly Streptococcus pyogenes and Staphylococcus aureus, and it's spread via direct skin-to-skin contact or through contaminated items, which is why children often get it because they're at daycare and they're all touching the same things and putting their hands in their mouth, so that's why it's commonly seen in children. Now, the main symptoms of this infection are red sores or blisters, this honey-colored crusting, itching or tenderness, pain, and a rash. Impetigo is usually a mild condition, though, and it can usually be treated with topical antibiotics and supportive care. Now, we knew that this was not the correct answer choice because impetigo typically does not cause systemic symptoms. This means we would not see a fever or photosensitivity in a patient with this condition. This condition would also cause sores, but would not cause oral ulcerations or rash to specifically appear in the malar area. It also has no association with Sjogren's disease, and if a patient had impetigo, they would present with this characteristic honey-colored crust that we do not see in our patient. So for all of these reasons, we knew that this answer choice was incorrect. Next, we have erythema multiforme. Now, this is an acute onset ulcerative disorder of the skin and mucous membranes. It's most likely immune-mediated, with 50% of the cases having an unknown etiology, 25% being due to a preceding infection, such as herpes, and 25% being medication-related. This is mostly seen in young adults between 20 and 30 years of age. Clinically, the patient will experience prodromal symptoms a week before onset, and those will include fever, malaise, headache, and sore throat. The presentation of the disease can have varying degrees of severity, which are differentiated as EM, or erythema multiforme, minor, and major. For EM minor, the skin is affected on the extremities and one mucosal site is affected, and for EM major, 2 or more mucosal sites are affected in conjunction with skin lesions. On the skin, we see round, dusky red patches known as targets or bullseye lesions. These are bulla with necrotic centers. Mucosally, we see characteristic hemorrhagic crusting of vermilion zones, which you can see in this picture, and erythematous patches on the mucosa that will undergo necrosis, resulting in shallow erosions and ulcerations with irregular borders. These oral mucosal lesions can be seen throughout the mouth, but will usually spare the gingiva and hard palate. Treatment involves systemic or topical steroids early on, as well as topical anesthetics or analgesics for the pain. The condition is usually self-limiting in 2 to 6 weeks, but 20% of patients get recurrences. Now, although this is likely another immune-mediated condition, we knew this was not the correct answer choice because erythema multiforme and lupus present very differently. Both can cause a fever and oral ulcerations, but erythema multiforme would not cause photosensitivity, the characteristic malar rash, and it is not associated with Sjogren's syndrome. And although the question doesn't specify the presentation of these oral ulcerations, the ulcerations seen in the 2 conditions do present very differently. Patients with EM would also present with the characteristic hemorrhagic crusting and bullseye lesions that we did not see in our patient, so we knew that this answer choice was incorrect. And finally, we have an allergic reaction. Now, there are a number of ways that an allergic reaction can present based on the type of allergen and the individual reaction of the patient's body. Because our patient is presenting with a rash on the face and oral ulcerations, we will focus on allergies and reactions that can cause those symptoms specifically, rather than reactions such as anaphylaxis. Now, allergic contact stomatitis, or allergy-induced inflammation in the mouth, can be due to foods, flavoring agents, certain dental materials, and many other agents. This stomatitis can present as mild or barely visible erythema to extensive erythema, erosions, and ulcerations on the mucosa. They may be asymptomatic, or they can cause burning, itching, or stinging. Allergic contact dermatitis is basically the same thing, but it presents on the skin, typically as a rash or as hives. Both of these inflammation responses occur when the tissue come in contact with an allergen and cause an immune response by the body. So how did we know that our patient was not experiencing an allergic reaction? Although we could possibly contribute her oral ulcer symptoms and her rash symptoms to an allergic reaction, that would mean that she is in contact with an allergen that she's both applying or rubbing specifically to those cheek areas of her face and putting inside her mouth, which is just not likely. An allergic contact dermatitis reaction would also not follow the characteristic pattern of that butterfly malar rash, meaning it would not spare the nasolabial folds or limit its spread to other areas of the face. Allergic reactions would also not cause photosensitivity, a fever, or have any association with Sjogren's disease. A final reason we know that this answer choice was incorrect is because these symptoms would subside if we were able to pinpoint and remove the allergen, but this patient's symptoms would not subside without proper treatment. So when you have a patient with the characteristic malar butterfly rash, when she has oral ulcerations, photosensitivity, and her sister also has Sjogren's syndrome, you know that she likely has systemic lupus erythematosus. We have a 43-year-old female who says, I have sores and ulcers in my mouth that won't go away. She has hypertension, type 2 diabetes, diffuse joint pain for 7 months, protein and microscopic blood in her last 2 weeks ago. She's taking some medications, her blood glucose is high, her blood pressure's fine, she has a fever, there are ulcers present intraorally, she has a positive direct Coombs test, and a positive anti-double-stranded DNA antibodies test. And we're asked, what is the most likely diagnosis? Now, we are definitely given a ton of information in this question to be able to make the correct diagnosis. There are a number of symptoms seen in the correct diagnosis that this patient is presenting with, including a fever, diffuse joint pain or arthritis, and these intraoral ulcers. There are also some important lab findings or results in this patient that really point us towards the correct diagnosis if we're familiar with them. This protein and microscopic blood in her last physical would represent proteinuria and hematuria, or proteins and blood in the urine, and as well as this positive result for an anti-double-stranded DNA antibody test. Now, all of this can seem like an overwhelming amount of information, and you may not be familiar with the lab results for these conditions, which is okay, because we can still answer the question based off the symptoms we're given and the symptoms of other answer choices that are not being given. So our patient is not experiencing some symptoms that are seen in these other answer choices. So it's what you're given and what you're not given that we can use. Now, we're looking for a condition specifically affecting a middle-aged female, causing a fever, that is causing arthritis, that is presenting with intraoral ulcers. And out of these answer choices, the correct diagnosis would be C, systemic lupus erythematosus. Now, lupus erythematosus is the most common collagen vascular connective tissue disease in the US, and it comes in 3 forms, but we'll focus on systemic lupus erythematosus specifically because that was the correct diagnosis here. This condition is much more common in females, like our patient, and the average age of diagnosis is 31 years old. The condition has a waxing and waning nature, and the initial manifestations are typically a fever, weight loss, arthritis, fatigue, and general malaise, and we saw a few of these in our patient for sure. And honestly, the ones that we didn't see, she may still have been experiencing at some point and just not have noticed or made note of it. Now, oral involvement is seen in 5 to 25% of lupus patients, including ours, and these lesions can present as lichenoid or nonspecific ulcerations on the palate, buccal mucosa, gingiva, and vermilion zones. This condition also typically presents with a characteristic butterfly rash in the malar or cheekbone area that spares the nasolabial folds, and the condition presents with skin lesions that flare with UV exposure. It's likely that she is early on in her lupus diagnosis, so she may not have developed these symptoms at this point. There are a number of other less common manifestations of lupus that can certainly be seen as well. Renal symptoms, like renal disease or the proteinuria the patient is experiencing, heart issues, headaches, hematologic symptoms such as blood in the urine, or hemolytic anemia like our patient. And a side note on that, we know that she has hemolytic anemia due to that positive Coombs test, which it's totally okay if you didn't know that, but I just wanted to clarify what that test meant, but we definitely didn't need to know that to make our diagnosis here. Now, because lupus can involve a number of symptoms and often presents very differently between patients, it can be hard to diagnose. Some tests can be done to help make this diagnosis. Blood serum tests will be indicative of that positive anti-double-stranded DNA antibodies, as well as positive anti-nuclear antibodies as well. Treatment varies based on the specific symptoms and presentations, and the prognosis is also dependent on what organs exactly are affected. So although we know this is the correct answer based on her fever, her joint pain, her oral ulcers, and her lab results, let's go through the other answer choices and briefly touch on what they are and why they're incorrect in this case. We'll start with Sjogren's syndrome. This is an autoimmune condition that attacks the lacrimal and salivary glands, causing xerostomia and dry eyes. It may also be seen in conjunction with other autoimmune diseases, such as lupus or Hashimoto's thyroiditis. This condition typically affects middle-aged to older adults and has a very strong female predilection. Patients often complain of a dry, gritty feeling in the eyes and a dry mouth, as well as swelling of the parotid gland we kind of see pretty often. Other oral findings that typically come alongside this diagnosis include cervical caries, increased candidiasis, and burning feeling of the tongue. Diagnosing this condition can be difficult as there are specific international classification criteria for Sjogren's syndrome. Treatment for this condition includes hydration, artificial tears and saliva, and medications that induce salivation. Now, why is this answer choice incorrect, especially if it's commonly seen alongside lupus? We are given so much information about our patient, but none of it indicates the common symptoms of Sjogren's syndrome. The patient does not seem to be suffering from dry eyes or a dry mouth, and she definitely would be if she had this syndrome. The syndrome is also not associated with these other symptoms like a fever or arthritis. And although some of the antibody lab tests can present similarly since they're both autoimmune conditions, this also would not cause proteinuria or hematuria. Because of all of this, this answer choice is definitely incorrect. Next, we have rheumatoid arthritis, which I'm sure you've definitely heard of. This is a chronic autoimmune disease where the body mainly attacks the synovium of the joints, leading to pain, stiffness, and swelling. This condition can also cause damage to other body symptoms, including the skin, lungs, heart, and even the mouth. Now, how do we know that this is not the correct answer? The patient is suffering from diffuse joint pain. Now, although both of these immune-mediated conditions are more common in women and both can cause joint pain, they're very different conditions. Rheumatoid arthritis also characteristically presents with stiff joints alongside joint pain, which we do not see in our patient. And although this condition can cause oral lesions and skin lesions like lupus, they present very differently. The skin may have small lumps or nodules that form instead of a characteristic malar rash, and the mouth may become dry or have gingival inflammation, but oral ulcers do not form. We also do not see a fever in this condition or the same lab results as we saw in our lupus patient. And then finally, we have dermatomyositis and polymyositis, mouthful there. These conditions are inflammatory diseases of the muscles that result in weakness. Polymyositis affects mainly the muscles, while dermatomyositis can cause skin lesions in addition to muscle inflammation, which makes sense if you think of the derm portion of the name that refers to skin. These are both systemic conditions, and although they mainly affect the upper arms and thighs, they can also affect other organs as well. The generalized muscle weakness seen in these conditions usually develops gradually and is most common in adult women. Beyond difficulty moving, this condition can also cause difficulty swallowing, breathing problems, and increase the risk for aspiration pneumonia. In dermatomyositis, the skin presents with a characteristic heliotrope rash around the eyes, which you can see in this image, and Gotron papules, which are flat red papules commonly seen on the hands and arms. Unfortunately, there is currently no cure for this, but treatments to improve muscle strength and function range from medications to physical therapy. Now, we know that this answer choice is incorrect because the symptoms and findings are very different among these systemic conditions. We would not see a fever, arthritis, or oral lesions in a patient with these two conditions, and we would not see dramatic generalized muscle weakness in a patient with lupus. And although both lupus and dermatomyositis can cause rashes on the face, the characteristic heliotrope rash is seen around the eyes, while the characteristic malar rash is seen on the cheekbones. They're seen in very different places. The lab results seen in our patient would also not appear in these conditions, and for all these reasons, we know that this answer choice is incorrect. So whenever you see a patient with a fever, with arthritis, with oral lesions, with proteinuria and hematuria, and with these lab results, especially in a middle-aged female, we know that she is experiencing systemic lupus erythematosus. This question is asking, each of the following is a common allergic reaction to dental amalgam except one. Which one is the exception? Contact dermatitis, anaphylaxis, oral lichenoid lesions, or gingivitis. So that means 3 of these are common allergic reactions and 1 is not. Now, although it is estimated that less than 1% of the population actually is allergic to dental amalgam, allergic reactions do happen, and it's important as the dentist to be able to recognize the signs and symptoms associated with these allergic reactions. So out of these 3, the one that is not an allergic reaction would be B, anaphylaxis. Now, I'm sure you're aware of what anaphylaxis or anaphylactic shock is, but just in case, let's go over it. Now, this is a severe, life-threatening allergic reaction that usually happens within seconds or minutes after exposure to an allergen. Your immune system's kind of freaking out, it's releasing chemicals like histamine that cause your blood pressure to drop, you get closing or constriction of your airway that make it really difficult to breathe, and you can often have hives appearing all over the body as well. Now, like I said, this is life-threatening. It needs to be treated right away with an epinephrine injection, also known as an EpiPen. So a common example of this that a lot of people know is a peanut allergy. Someone is deathly allergic to peanuts. If they eat one, they get this anaphylaxis or anaphylactic shock, they can't breathe, and you need to give them this EpiPen or epinephrine injection right away to make them feel better. Now, the most common dental cause of anaphylaxis is typically latex, either with gloves or rubber dam, but it's definitely not amalgam. Now, I'm not saying this could never, ever happen. It's just definitely not a common allergic reaction to a dental amalgam. These reactions we see to dental amalgam are usually not as severe as anaphylaxis, and we'll see that as we talk about the other answer choices. Now, before we go into each of these answer choices, I want to kind of show you an example of what an allergic reaction to dental amalgam typically presents as. So we see that little white lesion. That's what we're usually seeing. We're not usually seeing this severe, life-threatening anaphylaxis. So let's go through these other answer choices. And we'll start with A, contact dermatitis. This is also called contact stomatitis when it's specific to the mouth. So dermatitis could mean, the skin, any where in your body. Stomatitis is specific to the mouth, so it's also known as contact stomatitis. Now, this ranges from mild or barely visible erythema to extensive erythema. You can have edema, erosions, ulcerations, and even exfoliation. Now, this may be asymptomatic, especially when it's mild, but it can also cause burning, itching, or even stinging in the mouth. Now, to diagnose this, you want to identify temporal relationship between contact with the agent and oral changes. So if you just got an amalgam filling yesterday and you're seeing these symptoms, you might want to associate that time connection between the two. Hey, these symptoms kind of appeared right after I got that amalgam restoration done. But if you're unsure, you can also do something called patch testing to make sure. Now, like I said, this is a common presentation for an amalgam reaction, similar to how some people, when they wear a certain metal in jewelry, they get contact dermatitis, they get a little bit of a rash. So it's kind of the same thing that we're seeing here, just with the amalgam. Next, we'll talk about oral lichenoid lesions. Now, this is referred to as lichenoid because the mucosal alterations we're seeing mimic lichen planus, but these are localized and have a direct cause. Now, these lesions are associated with old amalgam restorations, not one that was just placed, and these are undergoing corrosion and releasing metallic ions. Now, this is limited to mucosal surfaces directly in contact with the restoration, such as the buccal mucosa, the ventral or lateral tongue. These can be white or erythematous. They can or cannot have peripheral striae, and to treat these, you want to either smooth, polish, or recontour that old amalgam restoration that's releasing these ions. And if you want to, you can also replace the amalgam with a non-metallic restoration if you think it's necessary. Although I said this is another common allergic reaction to amalgam restorations, I want to point out again that this is with old amalgam restorations. This is not you place it and then you get a reaction. This is an amalgam restoration that a patient has had for a while. So it's an important detail to kind of differentiate it from other common allergic reactions to dental amalgam. And finally, we'll talk about gingivitis. Now, once again, I'm sure you're aware of what gingivitis is, but let's just talk about it a little bit. Gingivitis is irritation and redness of the gums that is reversible, unlike periodontitis. Now, gingivitis can be caused by a number of things, but the periodontal field has a whole category called non-plaque-induced gingivitis. So although plaque is the most common cause of gingivitis, there are a number of things that can cause gingivitis that are non-plaque-induced, and amalgam is one of those. And a common allergic reaction to dental amalgam is gingivitis. So in the case of an amalgam allergy, it's a hypersensitivity reaction due to contact with that amalgam, making it a type 4 reaction mediated by T cells. That's what we're seeing here. That's what's causing this irritation, this gingivitis. So this gingivitis is seen 12 to 48 hours following contact with that allergen, with that dental amalgam, and it will be resolved when the contact is either removed or necessarily over time it could just go away, kind of like when you have an allergy on your skin. So contact dermatitis, oral lichenoid lesions, and gingivitis are all common allergic reactions to dental amalgam, but anaphylaxis, which is a very severe life-threatening allergy, is definitely not something that we commonly associate with dental amalgam. So be sure to look out for these other common allergic reactions, but you don't usually have to be worried about anaphylaxis. We have a 50-year-old female who says, my mouth feels dry and I cannot chew a cracker. She has hypertension, seasonal allergies. She's taking medications for the allergies, and we notice her blood pressure is normal. She has swollen lacrimal and submandibular glands bilaterally. She has xerostomia, or a dry mouth, and fissured tongue. Is experiencing halitosis, or bad breath. And we're asked which condition is the patient likely suffering from. And in this image, you can see those swollen lacrimal and submandibular glands bilaterally. Now, is it a malignancy? Is it diabetes mellitus? Is it Sjogren's disease? Or is it mumps? Now, we are given so many clues in this question to be able to make an accurate diagnosis for this patient. The first huge clue I want to point out is the fact that this patient has xerostomia. This is actually her chief complaint, as she says her mouth feels so dry and she cannot even chew a cracker. Now, dry mouth can be attributed to many causes, but it is associated with specific conditions, so we definitely want to keep those conditions in mind. The other huge clue is the fact that she has swollen lacrimal and submandibular glands bilaterally. Honestly, this clue alone was enough to diagnose this condition because it shows us exactly what parts of the body are being impacted. So since this patient is experiencing issues with her lacrimal and submandibular glands, and because she's experiencing xerostomia, we know that she has Sjogren's disease. Honestly, there were a number of other helpful clues we could have considered as well while trying to make this diagnosis. The fact that she is female and the fact that she has halitosis and a fissured tongue all make her a pretty textbook case for Sjogren's disease. But what is Sjogren's disease? Let's talk a bit about it. Now, this is an autoimmune condition that attacks the lacrimal and salivary glands, causing xerostomia and dry eyes. It may also be seen in conjunction with other autoimmune diseases such as lupus or Hashimoto's thyroiditis. This condition typically affects middle-aged to older adults and has a very strong female predilection. Patients often complain of a dry, gritty feeling in the eyes and a dry mouth, and swelling of the parotid is often seen as well. Other oral findings that typically come alongside this diagnosis include cervical caries, increased candidiasis prevalence, and burning feeling of the tongue. Now, diagnosing this condition can be difficult as there are specific international classification criteria for Sjogren's syndrome. Treatment for the condition includes hydration, artificial tears and saliva, and medications that induce salivation. So because she is such a great textbook example of this condition, we are confident that this is the correct answer choice. But let's go through the other answer choices and discuss what each condition is and why we knew it was not the correct answer choice for this question. And we'll start with the malignancy. Now, there are a number of malignancies that can present with some of her symptoms, but no malignancy will present with all of them together. For example, certain malignancies of the salivary glands, such as adenocarcinomas and mucoepidermoid carcinomas, could absolutely impair saliva production, and they could even present as a swelling in the affected gland. But we knew this was not the case because, number one, the chances that she would have bilateral malignancies in these glands is incredibly low. And two, this would also not cause her lacrimal glands to be swollen. A malignancy in her salivary glands would not cause the lacrimal glands to be swollen as well, even more bilaterally. Now, these malignancies would also typically present with other symptoms such as pain or tenderness, difficulty swallowing, numbness, and even an altered taste. So because her swellings are bilateral and because her lacrimal glands are also affected, we knew that this was likely due to an autoimmune cause such as Sjogren's disease, making this answer choice incorrect. Next, we have diabetes. Now, diabetes is a group of metabolic disorders resulting in hyperglycemia, and it is a defective or deficient production of or response to insulin. Now, insulin is a major anabolic hormone that allows glucose to be transported and stored in cells within the body after meals. There are two major types of diabetes, which I'm sure you're familiar with, type 1 and type 2. Type 1 diabetes is a chronic autoimmune disease where the beta cells of the pancreas get destroyed by self-reactive T cells and autoantibodies. This results in absolute deficiency in insulin production. This is typically seen in younger patients and is characterized by decreased blood insulin. Type 2 diabetes is not an autoimmune disease and is either the result of insulin resistance or decreased insulin secretion. The target tissues may not be responding to the produced insulin, or the pancreas may not be producing enough insulin for their body to function. This is seen in older patients and is associated with obesity. Now, both types of diabetes can have a number of complications and symptoms. Diabetes is the leading cause of end-stage renal disease, blindness, and lower limb amputation, and a number of other complications are also seen. As also, other symptoms, the 3 P's of diabetes, are very common and likely the most well-known symptoms, and they would be polyphagia, which is extreme hunger, polydipsia, which is extreme thirst, and polyuria, which is increased urine production. Now, although diabetes can certainly cause dry mouth, this is usually due to dehydration and increased blood sugar levels, not due to an autoimmune process. Diabetes would also not cause bilateral swelling of the submandibular and lacrimal glands, as is seen in this patient. If the patient had untreated diabetes, she would also present with other symptoms such as that polyphagia, polydipsia, and polyuria. And because she is not experiencing these symptoms, we knew that this answer choice was incorrect. And finally, we have mumps. Now, mumps is a viral infection that is very contagious and is thankfully not very common today due to the prevalence of the MMP, or measles, mumps, and rubella vaccine. Symptoms of the infection will show up 2 to 3 weeks after exposure, and the first symptoms are typically fever, headache, muscle aches and pains, loss of appetite, and fatigue. The characteristic swelling of the parotid salivary glands usually begins within a few days, and the swelling can be unilateral or bilateral and may be accompanied by pain or tenderness as well. That's what you're seeing in this patient, that swelling of the parotid glands. This patient in the image, not our patient. Complications associated with the condition occur when the virus spreads to other tissues in the body, and they can include decreased fertility, encephalitis, meningitis, pancreatitis, and hearing loss. There is no specific treatment for mumps, as most people will recover in 3 to 10 days. Any treatment given is to manage the symptoms, such as pain relievers or a warm cloth for those swollen parotid glands. Now, although mumps can cause the swelling of some salivary glands, it typically only causes the parotid glands to swell and not the submandibular glands like we see in our patient. We also would not see swelling of the lacrimal glands and a dry mouth in a patient with mumps, but we would see more muscle aches and pains, loss of appetite, and a fever. And because we do not see these symptoms in our patient, we knew that this answer choice was incorrect. So when a female patient especially presents with bilateral swelling of the submandibular glands and lacrimal glands alongside xerostomia, you should always assume that they have Sjogren's disease. Also would not see swelling of the lacrimal glands and a dry mouth in a patient with mumps, but we would see more muscle aches and pains, loss of appetite, and a fever. And because we do not see these symptoms in our patient, we knew that this answer choice was incorrect. So when a female patient especially presents with bilateral swelling of the submandibular glands and lacrimal glands alongside xerostomia, you should always assume that they have Sjogren's disease.
This question asks, what finding is indicated by the arrows in the image? So let's take a look at our answer choices. First, we have an OKC. This would be a multilocular radiolucency in the posterior mandible. This is shown on the anterior mandible and is radiopaque, so this would not be the correct answer. Next, we have PCOD. This would be a radiopaque mixed or radiolucent lesion in the anterior mandible. Since this is radiopaque in the anterior mandible, this does not present with the same symptoms as PCOD in a dental patient, so this would not be correct. Next, we have ameloblastoma. Ameloblastoma is a radiolucent expansile lesion in the posterior mandible. This is radiopaque and in the anterior mandible and does not present with any expansion, so this is also not correct. Finally, we have a mandibular tori. Mandibular tori is a lingual bony exostosis on the mandible that presents typically in the anterior, making option A the correct answer to this question.
This question is asking each of the following is a characteristic or feature of Sjogren's syndrome except one. Which one is the exception? High prevalence in women, T-cell mediated, causes a dry mouth, or causes excessive lacrimation. Now, before we talk about which of these features or characteristics is not associated with Sjogren's syndrome, let's talk about Sjogren's syndrome as a whole. Now, this is an autoimmune condition that attacks the lacrimal and salivary glands, causing xerostomia and dry eyes. It may also be seen in conjunction with other autoimmune diseases such as lupus or Hashimoto's thyroiditis. This condition typically affects middle-aged to older adults, and it has a very strong female predilection. Patients often complain of a dry, gritty feeling in the eyes and a dry mouth, and swelling of the parotid is often seen as well. Other oral findings that typically come alongside this diagnosis include cervical caries, increased candidiasis prevalence, and burning feeling of the tongue, which that dry mouth really contributes to. Now, diagnosing this condition can be difficult as there are specific international classification criteria for Sjogren's syndrome. Treatment for this condition includes hydration, artificial tears and saliva, and medications that induce salivation. Now, based off of everything we just said about Sjogren's syndrome, it should be very obvious what the answer choice is. The one that is not a feature of Sjogren's syndrome is D, excessive lacrimation. This is actually exactly the opposite of a defining feature of Sjogren's syndrome. Now, if you did not know what lacrimation was, it just refers to the secretion of tears, especially in a high amount. This is because tears flow out of the lacrimal glands. So lacrimal glands, lacrimation, you can see where it kind of comes from. Now, in this syndrome, the lacrimal glands, alongside the salivary glands, are actually attacked and are not functioning correctly, creating dry eyes and dry mouth. So instead of excessive lacrimation, we see insufficient lacrimation. So we know that this answer choice is incorrect. So even if we didn't know that the other answer choices were definitely features of Sjogren's syndrome, we should have been able to pick this answer choice because it is the opposite of the truth about this condition. Now, although we know that the remaining answer choices are definitely characteristics or features of Sjogren's disease, let's still go over them briefly. And we'll start with high prevalence in women. Now, autoimmune conditions in general are more common in women, and Sjogren's is no exception to this. In this condition specifically, there is a 9-to-1 female predilection, meaning that it is way more common in women. Now, men certainly can have this condition. It definitely is possible, but it's very true that it has a high prevalence in women, making this answer choice incorrect. Next, we have the fact that it's T-cell mediated. Now, we didn't specifically mention this earlier, but this is also a true feature of Sjogren's. In this autoimmune condition, the body's immune system is attacking the lacrimal and salivary glands, and the cells that are mainly responsible for this inflammation and damage to these glands are the T cells. These cells often are overly activated and are recognizing autoantigens as foreign bodies, leading to an aggressive autoimmune attack. Now, because this condition is T-cell mediated, we know this answer choice is incorrect, but I do want to repeat that even if you were unsure of this, even if you just knew it was autoimmune but you didn't know it was due to T cells, we still should have picked excessive lacrimation because that was just completely the opposite of what is seen in Sjogren's. So don't let the things that you don't know trip you up. If you know something's absolutely wrong, you can still pick it for these exception questions. And finally, we have dry mouth. This is not only a feature or characteristic of the condition, but is basically a defining quality of Sjogren's syndrome. Because the T cells are attacking the lacrimal and the salivary glands, xerostomia, or a dry mouth, it's just another word for dry mouth, is one of the major symptoms of the condition alongside those dry eyes. So we definitely knew that this answer choice was incorrect. So we know that when talking about Sjogren's syndrome, we see a high prevalence in women, we know that it is T-cell mediated, and we know that affected patients have a dry mouth. We do not see excessive lacrimation in this syndrome, but would instead see insufficient lacrimation. This question is asking which age would intake of a tetracycline most likely have the greatest effect on the crown of a permanent mandibular central incisor. This question is kind of a two-step question because it requires us to know what effect tetracycline has on developing teeth and when this effect occurs. Now, tetracycline is a broad-spectrum antibiotic that is used to treat many infections, but one of its side effects is incorporation into tissues that are calcifying at the time it is being taken. This is due to the antibiotic's ability to chelate calcium ions, allowing them to be incorporated into bone, cartilage, and even teeth. When these antibiotics become incorporated into the calcifying teeth, whether they be primary or permanent, it results in a yellow to gray to brown discoloration or intrinsic stain, with the color determined by the total dosage taken over a certain time period. This discoloration does not cause any weakening to the teeth, but can cause obvious aesthetic problems for patients. Now, there are a number of treatment options for this staining depending on its severity, including internal bleaching, composite and porcelain veneers, or even crowning the teeth if decay is also present. Now that we've discussed the effect tetracycline has on the dentition, we know that the correct answer choice for this question has to be when the permanent mandibular central incisor is calcifying. It's important to know different calcification dates specifically for questions like this on the boards, but overall, the primary dentition begins calcification as a fetus, while the calcification of the permanent teeth begins after birth. But even if you don't know exact calcification dates, you should be able to determine what the correct answer choice is for this question if we think logically. We know it occurs after birth because it's a permanent tooth, and this tooth is already erupting by age 6, so the crown of the permanent mandibular central incisor must be calcifying around C, 4 months, making it the time period when tetracycline would have the greatest effect. The permanent mandibular central incisor begins calcification around 3 to 4 months, and the crown is complete around 4 to 5 years, with the tooth eruption occurring between 6 and 7 years of age. It's safest just to avoid tetracycline in a child until they're around 8 years of age to prevent any discoloration from occurring as other teeth are still calcifying up to that point. A pregnant woman should also avoid taking tetracycline, especially in the 2nd and 3rd trimesters, as that is when a baby's primary teeth are calcifying. Now, although this is definitely the correct answer for when tetracycline would have the greatest effect on a permanent mandibular central incisor, let's go through the other answer choices and discuss what effect tetracycline would have at these time periods. So we'll start with the 4th fetal month. Around the 4th fetal month is when calcification begins for all primary teeth, from the central incisors to the 2nd molars. A pregnant woman taking tetracycline at this time period could cause discoloration in any of these teeth, but this would not cause any effect on the permanent mandibular central incisor because it has not begun to calcify yet. Because of this, this answer choice is incorrect. kind of the same thing for this 8th fetal month. Around the 8th fetal month, the calcification process is still occurring in all of the primary teeth, and the formation is actually not completed until after the baby is born. A pregnant woman taking tetracycline at this point could still cause discoloration in any of these teeth, but this again would not cause any effect on the permanent mandibular central incisor because it has not begun to calcify yet. Because of this answer choice is also incorrect. And then finally, 6 years. Because tetracycline can only be incorporated into a structure that is calcifying, a 6-year-old who is taking tetracycline would not experience any discoloration of their permanent mandibular central incisor because the tooth has finished calcifying by this point. This tooth is likely actually erupting at this point, like we said, as the typical eruption age is 6 or 7 years. Although this time period is too late to cause discoloration to that permanent mandibular central incisor, it is not too late to cause discoloration in other permanent teeth that are likely still calcifying, such as the canines, second premolars, and second molars. This is why, once again, children should not take tetracycline until they are older than 8, as that is when all permanent teeth, not counting your third molars, have finished calcifying. So we know that when talking about the time period when tetracycline will have the greatest effect on a tooth, we need to know when that tooth is calcifying. And for this question specifically, we know that the permanent mandibular central incisor is calcifying when a baby is 4 months old.